This we move on to the fifth session of today's scientific feast, and the session would cover antibacterial and antifungal stewardship in diabetes. To speak on this particular topic, I would like to invite Dr. Subhadip Pal, physician, acute and internal medicine, Kolkata, head of critical care, Sharonna Multispeciality Hospital, Bardhaman. He has several national and international publications and is attached as faculty at several organizations. To chair this particular session, I would like to invite Dr. Anirban Kormokar. He is a senior consultant critical care specialist at Narayana Super Speciality Hospital and director critical care at B.M. Birla Heart Research Center. Along with him, I would also like to invite Dr. Abhrojit Raha, who is a young enthusiastic educationist and critical care specialist. We also have Dr. Bihan Nyogi as the chairperson. He would be joining us shortly. He is a consultant critical care medicine and ICU in charge of Narayana Super Speciality Hospital. I welcome the speaker and chairpersons, and I would request the chairpersons to introduce our speaker today.
We started with a glitch. This is quite expected to happen because amongst this crowd of diabetologists, probably this is one session which is more metaphilosophical than diabetic oriented in true sense. So, respected chairpersons and distinguished delegates, we are supposed to discuss about antimicrobial stewardship or antibacterial and antifungal stewardship in diabetic patients. And I would start off knocking the very important question that is antimicrobial stewardship more important in diabetics in true sense? Or is it that we are hosting a national conference on diabetes and we wish to know that whether diabetic patients need a different approach in antimicrobial stewardship? I would present, amongst the many studies that are available over the net, I would present only two studies, both of them pretty old, one from 2015, saying that excess risk of dying from infectious causes in those with type 1 and type 2 diabetes. You would find a host of such studies, but what intrigues me in this study is that it is in this study that they have clearly said that they confirm, it's a very emphatic statement saying that we confirm that patients with diabetes have an increased mortality from a range of infections. And secondly, it is here that in the most unskewed statistics, they have said that the increased risk appears to be greater for type 1 than type 2 diabetes. As clinicians, as internists, we probably know that the risk is higher with type 1 diabetics, but it is here where we first saw it being established statistically and very emphatically. And coming to another national cohort, don't sniff your noses, it's from South Korea, and it says that diabetes and the risk of infection goes hand on hand. If you are a little disappointed about South Korea, look at the size of the sample. More than 66,000 patients who are having diabetes compared against controls of 132,000 non-diabetic patients and followed up for a mean of 7.8 years. And the essence was in a fantastic one-liner. They said people with diabetes has a considerably higher incidence of infection-related hospitalization and deaths than the general population. And that probably clearly explains why the organizers or even myself were interested to find out whether antimicrobial stewardship holds something different of a promise for patients of diabetes having infections. And this is the most current document, Diabetes and Infection, a review of epidemiology, published in February 2024, which says the same thing. Compared with the general population, people with diabetes have a 2 to 4-fold increased risk of infection-related hospitalization and a 1.5-fold increased risk of infection presenting in an outpatient setting. So that set the context, that says why we are here discussing about antimicrobial stewardship more seriously being applied for diabetic patients. So Why infections, do you think, are more deadly in diabetics? There are twofold reasons. First of all, if you see, the infection brings about, pardon the mistyping, the infection brings about certain inflammation in the islet cells, which diminishes the already diminished insulin secretion. And the infection, on the other hand, increases productions of stress hormones. There's a cytokine storm of a thing which increases insulin resistance, and both of which contribute to hyperglycemia. And if you have accepted or appreciated that hyperglycemia, the relation between hyperglycemia and infection is bidirectional. On one end, infection will increase insulin resistance, beta cell dysfunction, causing hyperglycemia, which in turn hammers on the already paratic, already weakened innate and adaptive immunity system and the host-specific factors which increases chances of infection and the virulence of infection, to be precise. Here is a long but not complete list of infections that are more common in people with diabetes or that have increased risk of hospitalization or poorer outcomes. And this is exactly why we talk about antimicrobial stewardship. This is exactly why we think antimicrobial stewardship holds more promise and a better position for diabetics compared to non-diabetic individuals. But to be honest, as I was side talking with one of my chairpersons, there is no such separate antimicrobial stewardship guidelines or propositions for diabetic population. Now, what is antimicrobial stewardship? It is, or it refers to the optimal selection, dosing, and duration of antimicrobial treatment. Sounds easy, but that is the most difficult thing that we happen to see in practice. We happen to see doxycycline and azithromycin being pumped into people with flu-like illnesses. We always see higher dose of quinolones being pumped into pyrexia of unknown origin in a patient who is a diabetic and having a clear urinary tract infection with a culture sensitivity report where quinolones are all insensitive. So we need to be more responsible, and that is what antimicrobial stewardship is all about. Stewardship is something different from diagnostics and therapeutics, and probably I'll come to it at the end if I have time. So this is a fascinating 5-unit chain of WHO antimicrobial stewardship principle. This came way back in 2015 on the Open WHO platform, and it gives us a clear idea about where we should concentrate so far as antimicrobial stewardship is concerned. This holds more importantly significant for our diabetic patients. First of all, the severity. You need to be very particular about the severity in your patients, because unless you are gogging the severity, you are not going to formulate the attack you are going to launch on the infection with your antimicrobials. Source isolation and source control is very, very important, because in diabetes we have things like skin infections which often progress and become a fasciitis. We have diabetic foot infections. We have ordinary urinary tract infections which become extraordinary with passage of time. So it's very important to identify and control the source at the outset, more so in diabetic patients. Diabetic patients suffer from recurrent infections, hospitalizations. They have IVs more than their non-diabetic counterparts, and hence they are more prone to have resistant bugs in their systems. So whenever we are dealing with a severe infection in a diabetic, so far as antimicrobial stewardship is concerned, it takes into consideration the drug-resistant part. That means at the back of your mind, right at the beginning, is that there is a resistant bug in a high propensity and probability in the system. We need to take patient factors into consideration. Think of a diabetic patient who almost always in the long term might have end organ dysfunctions. May it be a hepatic dysfunction, it can be a diabetic nephropathy, and that tempts us, that urges us that we alter, modify the dosage of the drugs we are using. And that is where antimicrobial stewardship sips in. Like For example, a patient with a urinary tract infection might come up with a blood culture, urine culture report where moxifloxacin is highly sensitive. But we all know that such patient with nephropathy, we have a temptation to give moxifloxacin, which is not secreted properly into the system. So whenever we think that we are going to give something to the patient, think of the background of the patient and the patient factors that come within. Similarly, this same patient with a pyelonephritis, suppose we are planning to give a carbapenem, a simple visualization of a creatinine of say 1.7, we think will halve the dosage. So we drop from 1 gram thrice a day to half a gram thrice a day. But if you translate the creatinine as a routine to glomerular filtration rate estimates, you would find that this patient should have received a dose of 1 gram twice a day. So the dosage was suboptimal. So patient factors are very, very important for all patients, but more so in case of diabetic patients, where the PKPD, the handling, the redistribution of the drug, the antibiotics are all altered, and they all need to be taken into account while prescription is being made. And finally, the cultures. Cultures need to be sent so far as practical before prescribing the antibiotic. It's often a very, very prismatic term, You have a patient who is receiving antibiotics every alternate week. So you don't get an antibiotic window. You don't get a period of antibiotic-free culture posting. But still, you need to send cultures. But cultures, in coming days, I believe, would be an insignificant part of antimicrobial stewardship. And I'll tell you why. Remember that this WHO chain holds equally good across the glycemic spectrum. For someone with a poor glycemic control or someone with a good glycemic control with a severe infection, this chain is to be maintained, this philosophy is to be maintained in practicality. The 7 core elements of antimicrobial stewardship, just for a reference, I wouldn't go into it, but certainly we'd point out to the core features of antibiotic stewardship and then discuss with you, according to this very interesting readout article, diabetes-associated infections, development of antimicrobial resistance, and possible treatment strategies, which is there from 2020, and there was a fantastic editorial that came up in March 2022. Now, improving infection prevention and control program, minimizing the source of infection is the first thing you should practice. And to do that, you should have a functional infection control committee with appropriate structure. Having said that, most of the hospitals now have a hospital infection control committee, and that HICC is primarily on pen and paper to be presented to the NABH assessor when he comes in. But you should have a functional infection control committee with trained infection control personnel. Even 3 years back, we didn't have very structured courses for infection control. But now, fortunately, we have online, on-site, even hybrid courses where we can train our doctors, our registrars, even our paramedics in infection control nuances and make them worthy members of our infection control team. Implementing tested and certified infection control measures and putting AI or artificial intelligence-driven strategies and newer technologies in place. That is the call for the day. And so far as practicable, it's not possible in all centers, it's not possible in all clinics and OPDs, but this is what will draw the picture in future. And then you have several other factors that need to be practiced. Prescribing antimicrobials only when indicated. I just now said prescribing a quinolone for a simple diarrhea is just but a crime. Selecting antimicrobials rationally with precise and optimal dosage schedule. Do not compromise on dosage if you are thinking that this person is having a diabetic nephropathy. Have a clear EGFR before you make the dose cartel bend. Prescribing antimicrobials for a brief period on basis of evidence, not more than the period that is on the evidence burden. And finally, assessment of prescribed antimicrobials based on culture sensitivity or other diagnostic reports. So, running antimicrobial prescription audits and putting in place unbiased and foolproof system without missing any advice is one very important issue in this regard. Adopting guidelines specific for the country, state, and even the healthcare arena. I'll give you such guidelines in a moment from now. Involving the pharmacologist, the microbiologist, ID specialists, and biostatistician in decision making, promoting the interdisciplinary strategy which can actually give you the holistic outcome towards antimicrobial stewardship, honestly upholding the antimicrobial resistance and healthcare associated infection data for scrutiny. Most of the organizations, most of the hospitals will shy away from giving the sordid picture if it is there. And finally, monitoring the antimicrobial consumption on a monthly or quarterly basis. So these are some treatment guidelines that are available with us already. The treatment guidelines for antimicrobial use in common syndromes, which is available as a fantastic application on both iOS and Android platforms. We have our own state-specific guidelines, that is antibiotic guidelines that were published in 2023, and the fantastic guidelines for antibiotics prescription in critically ill patients, none other than my revered teacher, Dr. G.C. Khilnani, with contributions from our own Dr. Subhash Todi and Dr. Shusruto Bandyopadhyay. If you look at the antifungal stewardship story, you would see the core elements of antifungal stewardship are all but the same. There's not much of a difference. And due to the paucity of time, I will just pass on by saying that since it is a microbe, the same principles, the same philosophy applies for the core elements of antifungal stewardship. But then again, it's time to look beyond cultures and guidelines. And this is my opportunity to tell you that only cultures marked by zone diffusions or plus and minus signs or R, S, and I notations against an antibiotic will not hold good anymore. With super resistant bugs in the pipeline and no new antibiotics in the horizon, we need to concentrate on better interpretation of our microbiological results. We need to train ourselves and take the help of our microbiologist and ID specialist friends so far as practicable. Like MIC is a new term to us, but MIC alone isn't going to be of help unless you are coupling it up with the MBC, the minimum inhibitory concentration against the minimum bactericidal concentration. You have to think about newer techniques. Amongst the million newer techniques like the BioFire, the MALDI-TOFs, I am particularly fascinated by the next generation sequencing. This is not only going to give you a result on viruses, bacteria, and fungi at one go in less than 24 hours, but also give you a fantastic outlook on the resistance pattern in terms of the enzymes. You know, we now have terms like carbapenems producing Enterobacteriaceae, or we have ESBL producing E. coli. But that only is not going to help in future. We have mapped down all those ESBLs, A, B, C classes, and we ought to know, we tend to know that whether this is a CTXM or this is an OXA. And even though the culture sensitivity reports might come in 72 hours down the line, if we have a next generation sequencing, identifying the organism and giving the resistance pattern, we would be selecting or stewarding the antimicrobial in a much more effective manner than we are doing now. So, and for antifungals, in addition to next generation sequencing, we are aided with the beta-D-glucans and the galactomannan tests. From the Venn diagram, you can well see that these two tests coupled, although they are not reported around the same turnaround window, but we can have a gross idea as to if there's a fungal invasion, what type of a fungal element we are dealing with. Among the 4 classes of antifungals, we can have an idea about what strains might be prevalent in our setups, and we can choose more diligently and more religiously. So time to move ahead from non-culture-based culture-based methods to non-culture-based methods. Time to move ahead to have a team approach, to have a whole team involved in something that is going to claim lives of our diabetics. Not only diabetics, you might say that sepsis claims huge amount of lives. It collates to a large amount of mortality and morbidity. But then again, we have a completely collapsed immune system. We have a paratic immune system in our diabetic patients, and hence it's more important that we have a clear antimicrobial stewardship emphasis when we treat our diabetics with infection. So fortunately, before the bang goes off, I'm into the last phase of my presentation. As I was saying, I persistently and emphatically believe that stewardship is a philosophy. It is a philosophy of choosing the right. It is a philosophy of having a broader perspective of a very big problem and intensifying our knowledge and intensifying the team approach to get along and treat and save lives. Unless we have that metaphysiological and philosophical approach in the days to come, with the limited amount of antibiotics in our armamentarium left over and the super resistant bugs running havoc, will not be able to save our patients and especially our diabetic patients. So let's all be good stewards, protect patients and protect antibiotics. Thank you.
Thank you, Dr. Subhadip. That was an excellent overview of the AMS. Just wanted to ask you, as you said about the source control, I mean, how important is screening for mainly diabetic patients in terms of source control?
Well, source control will come for diabetic patients every now and then, because diabetic patients will keep coming to us with infections, and most of the times they will be overlapping so far as the source is concerned. I would have a patient who was admitted to a hospital with a pneumonia, for that matter, and 3 weeks down the line, the same patient would be admitted to me with a UTI. So I would be intrigued to know whether the LRTI he was suffering from has been controlled or not, or the focus is only with the UTI. And if the UTI is confined to the bladder or it has gone up to the pyelonephritis level, otherwise I will not be able to choose the right antibiotic. It might be so that this patient is going to have a prostatitis as well if the patient is a male subject. Maybe in some cases there's a skin infection, skin and soft tissue infection, interposed with a respiratory infection, and I need to involve my surgery friend. Otherwise, unless I have debrided a diabetic foot, I will not be able to source control whatever additional source of infection might there be in the patient.
No, more specifically, I want to know, is there any screening criteria or any tool you practice in your
right at this moment, there's no screening tool additionally that we'd be using. But then again, if the patient, we are sure about the infection, we try to emphasize on the interdisciplinary approach to find out what the source might be. Sometimes the source is quite obvious, sometimes it is not.
Hello, sir. It was a very enlightening lecture, especially for those who are not directly associated with stewardship programs and infection control. I'd just like to ask about your opinion about one thing. As far as antifungals in India are concerned, as you said, we don't really have non-culture-based diagnostic tests much in India. So, and whatever we have, the beta-glucans and mannan, antimannan, galactomannan, they have a variable specificity sensitivity. So, what is your opinion about enforcing scores, the recent scores, the equal scores for Candida and Aspergillosis and Cryptococcus, which are more based on clinical studies, have been as a class 2 recommendation in the IDSA? I mean, are we doing that regular? What is the provision of doing that?
Actually, in a lot of patients, you know, you'll appreciate that these days, not all of your patients would be able to even do beta-glucans and galactomannans. or next generation sequencing for that matter. So we are left over with those beautiful scores we have been relying upon for so many years. Now, those scores are always there. Even if I send the labs, even if I knock the labs with the next generation sequencing, I would still count a lot on those scores. And I would also say that in my practice, I have found that these scores corroborate to our perception of the infection or suspicion about the fungal element in more than 70% of cases. We would get clinical results even by interpreting these scores and using empirical antifungals. But more and more, with passage of more and more days, I am actually becoming reliant a lot upon my microbiologist and ID specialist friends whenever they are available. And I think in days to come, that is one ethical way everyone should go forward.
Right. Thank you so much. Thank you so much, sir.
The now topic is open for the audience.
Yeah. Actually, I was looking for some data since you were speaking on antimicrobials and infections.
Sorry?
In HIV, we have a data, what is the annual risk of development of tuberculosis? Globally and in Eastern India are established. Now, is there any such figure for diabetes mellitus type 1 or type 2, the annual risk of development of tuberculosis or lifetime risk?
Might
Anyway.
be, sir, not that I know of, but I was actually presenting a very recent literature which was saying that it was just 2 to 4-fold higher in case of diabetic patients, and type 1 diabetics were more prone to relative or absolute risk of infections, and this was over a mean period of 3.5 years. So there were no definite figures as to type 1 diabetics and type 2 diabetics. But over and again, it has been proved, as you definitely know, that type 1 diabetics are easier targets for infection, and we are more concerned about a type 1 diabetic with an infection compared to a type 2 diabetes with infection, so long there is no organ dysfunction in the type 2 diabetic.
Yes, there has been no study here. Thank you. Whatever we have to go along.
So if there are no more questions, we would thank Dr. Subhadip. And I would say that, as they say, our future depends on what we do today. So we should be more conscientious in practicing the AMS. And as Dr. Subhadip said, it should not be an academic process or should not be in the pen and papers. We should practice that. Thank you, Dr. Subhadip. Thank you.
Thank you, sir, for the enriching presentation. I would ask you to kindly stay back for the felicitation. I request chairpersons to kindly felicitate Dr. Subhadip. I would like to invite Dr. Vismay Kumar to kindly felicitate our chairpersons. Sir, would you please kindly stay back? Dr. Abrojit Raha and Dr. Anirban Kormukar. Thank you, chairpersons. Thank you, speaker, sir.